and I trust everybody that can hear me. We have a nice group here this evening, and I'm really excited. People must be really interested in the topic, as well as our speakers. Um, this is Penelope or Penny Glenn, and I'm the coordinator for the President's Lecture Series on Health, which I think all of you know. And I thank each of you for attending this evening's event, given that it is the last day to turn in your taxes. But I think you'll be very glad that you came this evening. And I think it'll prove to be a very informative and very different evening. And I'll explain that in a minute. Um, Professor Shannon Hogan is your moderator for this evening. And he said people call him anything, but he actually can be called Hogan. Um, and all the other speakers likewise have said you can call them by their first name. Let me move the slide again. All right. Um, Before I turn it over to the moderator, Hogan, I do, as you know, have the particular slides that I have to show that the ANA Mass really requires me to do. And these are the things. First of all, if you are looking for contact hours, you must stay for the entire presentation. All right. Um, and that includes the question and answer period. At the end of the Q&A, you can click on the link for the evaluation form in the chat, which you do have to complete in order to get your contact hours. For course credit, you must include your faculty's name on the evaluation tool. And to get course credit or contact hours, you have to submit the evaluation, which I already said. So now let me go back here because okay. Here's what you can expect and when you can expect it. If you are a nurse and you want your contact hour certificate, you can expect it in an email in 7 to 10 days. If you are faculty and you are waiting for a list of your students, you can likewise expect it in 7 to 10 days. If you don't need contact hours or class credit, let me just see, I got a notification here. Let me just be sure this isn't something important. Okay, we're good. All right. Anyway, if you don't need contact hours or class credit, we really hope you'll fill out an evaluation anyway, because we really do take the feedback that you give us on the evaluation. It's very important. We do make changes, as you will see tonight, based on what you submit in your evaluations. These are the during the meeting reminders. Just remember to remain muted and turn your video off during the presentations. If you do want to make a comment, you can click on the chat icon. And I believe now it says to check to choose meeting group chat. I'm not sure if that's really changed, but that's what it showed me now. As you can see at the bottom here, to meeting group chat. If you do that, it's also helpful to include Shannon Hogan's name somewhere in the body of the message so that he sees it and knows that he also should be answering that question. If it really doesn't matter to you, then you don't have to include his name. All right. And then over here, um, during the Q&A, you can, if you want to raise your hand, which is what we encourage, if you want to raise your hand, you click on the heart on the bottom bar and open it up, and you will see what's on the screen here, all of these things, including raise your hand. So that's an important thing, and it makes for a more interactive event if you at least ask the questions in the Q&A, and it's even better when you raise your hand. Okay, I think that does it for me. There is one thing, there are a couple things here. Let me just go back. All right. Um, just to remind you that you must include your name on the faculty form. But the other thing is that's really important is you must change your Zoom name to your legal name for attendance purposes. And this is because your legal name is what is recorded, and that's how we know that you were there, and we know how long you were there, and we need that to verify sending your name to your faculty or sending out a certificate for contact hours. The other thing I want to remind you of, the evaluation survey is going to close at 8:30. All right. The one other thing that I have to say, which is important, is that this program was approved for 1.5 contact hours, and that's partially because we have 3 speakers, and we did decrease the amount of time because that's some of the feedback that we've gotten, and that 2 hours was a really long time. So that's part of why we did it, and I think that's everything, except now, before I introduce Shannon Hogan as the moderator, I'm going to stop sharing my screen. And that should be what I did, right? And now I should be able to end this. Let me see. Why can't I end this? All right. Let me just think a second here what I'm going to do. Uh, okay, right now I'm going to do that. Okay. And what I do want to do is I'm going to initiate a poll that we'd like all of you to answer. And there's really no right or wrong answers. It's really just to give the speakers a sense of the audience, who you are and what you know. So it's not a test, but I really would appreciate you doing it. And I'm going to launch it here. And everybody should be able to see this. Can you?
Yes.
I would imagine if my speakers can see it, then we're good. All right. So there are 5 questions, and you can go ahead and you can answer them all yourself. I'm not seeing anybody answer yet, so that's making me a little nervous. Oh, now we've got some people answering. Oh, thank goodness. All right. So then I know you're seeing it. And again, remember, these are sort of general questions. There's not necessarily a right or wrong answer. And we do expect that some people are really going to know it and some people may not. And I'm not going to go over the results here, because what should happen over the course of the panelists and the program is that you should find out the answers to these questions. And at the end, if people still don't feel comfortable with the answers, then I do have the answers and we can talk about them. But I don't want to do it before our panelists speak. Um, all right, I have about 53 people who have answered, and we have 79 in the audience. So I'll give it a little bit more time. Let's see how we're doing with the rest of them. Yep. Okay. All right. I'm going to give the poll about I'll give it to a total of 3 minutes. So you got a little more time to answer it. And again, it's just helpful for our panelists to see where we get. Okay, you have a few more. You have 10 seconds. All right, I ended the poll and I'm going to share the results. And I'm hoping that people can now see the results. Is that true? All right. Okay, we have 97% agree with that statement, the very first statement. Vaccination has health benefits, educational benefits, and economic benefits. That's quite a lot of people. That's a really nice number. Here we have it has been reported that vaccine hesitancy, while a significant concern, is not among the top global health threats. And we still have some variation here. So we have 33% agree and 67% don't agree. Then we have data show that the percent of parents indicating that parents should be able to send children to school without being vaccinated against preventable diseases has decreased since 2019. And we have 74% disagreeing and 26 agreeing. And then agree or not agree, the federal government is no longer a reliable source for evidence-based guidance for immunization. And agree 75% and 25% disagree. And our last one, you rating your knowledge level right now regarding vaccination and the topic that we're talking about this evening. And it looks like we have, 7% that really are going to learn a lot, 42% who have a basic awareness, 46 who have a moderate level, and only 5% who have a high level. So that should help our panelists. All right. And now I'm going to close this and I can turn it over to Professor Shannon. And let me just go back to sharing my screen and getting my intro slides. Where, oh my gosh. Uh, oh boy, they've gone. So now I have to go back. I'm sorry. I'm really sorry. Yeah, they closed out. So, okay, now I'm going to put this down and I'm going to hope that it'll share now. I apologize. Yep, here we are. Share. Why is, oh, that is so bizarre. Oh, this is awful. I'm going to stop my sharing and I'm going to try and find the PowerPoint again, which I can't. Just bear with me a moment. Ugh. I'm not quite sure why this is not working.
I can share them.
You can?
Yep, let me share my screen.
Okay. Okay, now you can go all the way to the speakers and I can turn it over to Shannon Hogan. I'm so sorry, Shannon.
No apologies. Quick clarifying question. If people have questions after each speaker gets done their presentation, are we holding those to the Q&A or are we asking
We
them?
hold them to the Q&A.
Every question gets held.
Yep.
Okay, that's all I needed.
All right. I'm so sorry.
Don't be sorry. It's fine. It's fine. I've seen worse. How about that? Okay, so hey everyone. Thank you so much for coming here. I'm Shannon Hogan and I will be your moderator tonight. So the topic, obviously, vaccines are one of the most successful scientific and public health tools that we've ever developed, ever. Yet we're at a moment right now where scientific progress alone is no longer enough. We're seeing global gaps in access. We're seeing national shifts in trust and policy, local changes in implementation that directly affect patient care and overall community health. So, what makes tonight especially important, in my opinion, is that these challenges don't exist in isolation. They're deeply connected from global supply chains to equity to public perception and trust to how policies are actually carried out on the ground. So, our panel brings together expertise across all three of those levels. And as we move through the discussion, I encourage you to listen to each perspective individually, but then sort of see how they all intersect and what that means for the future of immunization. So tonight we have three distinguished speakers bringing their perspectives to this topic. And the first one is going to be Stuart Landers. He's a public health expert whose work has focused extensively on healthcare systems, workforce capacity, and equitable access to care both in the United States and also globally. He serves as a board member of the Massachusetts Public Health Association and has worked as a senior consultant at John Snow Incorporated, which is a global public health organization. What makes Stewart's perspective especially valuable for tonight, though, is his ability to help us understand the broader global landscape, where vaccination efforts are succeeding, where progress is stalling, and the structural challenges that continue to shape and access equity worldwide. Next, I want to move to speaker two, which is Jillian K. Steelfisher. She's going to speak mostly on the national level. She's a nationally recognized expert in public opinion and health communication whose work helps us understand how people think about vaccines in public health in real world settings, so in actual settings. She's a principal research scientist at the Harvard T.H. Chan School of Public Health and a director of the Harvard Opinion Research Program, where her research focuses on how public attitudes and their experiences and behaviors shape responses to the major health challenges we're seeing today. What makes her perspective especially valuable for tonight is her ability to translate sort of the complex public sentiment into actionable actionable insights, kind of helping us understand what people believe about vaccines and why those beliefs form and how they influence decision making overall. And then our third speaker is Angela B. Fowler. She's going to speak mostly on the state level. She's a physician and public health leader who works at the intersection of policy, implementation, and patient care. She serves as an associate medical director for vaccine preventable diseases at the Massachusetts Department of Public Health, where she helps oversee immunization programs and ensures that policy, that vaccine policy, is effectively translated into practice across the state of Massachusetts. What makes Dr. Fowler's perspective very important for tonight is her ability to show how vaccination strategies are actually carried out on the ground, how systems are maintained, how access is ensured, and how public health efforts directly impact communities. So now I'm going to transition us to speaker one, which is going to be Stuart. And I'm just going to give you a little transitional phrasing here. So it says, to begin with, we're all going to start at the global level, where vaccination efforts are shaped by access, overall infrastructure, and broader public health systems around the world. Our first speaker, Stuart, will help us understand where progress is being made, where it's stalling, and what the key challenges are that continue to influence vaccine availability and also importantly, equity worldwide. With that, I invite Stuart as our first speaker.
All right. And now I'm going to share my screen, and I'm on that now, and I'm going to share it. And I'm going to go to slideshow and from the beginning. And that should be correct. Do people see it?
Yes.
Okay.
It is correct. Thank you, Penny, Shannon, Asme, and everyone connected to the President's Speaker Series for the opportunity to talk with you this evening. Next slide, please. Today, I'm going to provide an update on the global picture with respect to vaccines and immunization. I'll be describing certain aspects of the worldwide situation over the years, discuss some challenges to global efforts to expand vaccine uptake, including some significant inequities among the world's nations. Despite these challenges, I will end on a hopeful note with a look at future endeavors. Next slide, please. In 1796, Dr. Edward Jenner documented the first case of inoculation. Now, the idea behind this inoculation goes back a lot further. The practice of variolation was first used in China, India, parts of Africa, and the Middle East before it was introduced into England and North America in the 1720s. This entailed using the pus from an existing smallpox patient and injecting it into a healthy individual. It provided protection, but 1% to 2% of people, thus in using this method, died of the disease. The idea of using cowpox in a similar manner emerged in the late 18th century when it was noticed that milkmaids who had been exposed to cowpox seemed immune to the stronger infection, smallpox. Edward Jenner documented the inoculation of a pauper boy. It was actually, his name was John James Phipps. He was the 8-year-old son of Jenner's gardener. I think in some ways, this also documents the first inequities in immunization, when you see that sort of a person with very little power was inoculated rather than someone else who might have been more of an equal. Next slide, please. It's important to point out that there are two functions that vaccinations perform. The function most people think of is prevention of disease, and therefore the terms vaccination and immunization are often used interchangeably. And indeed, most of the vaccines I'll be talking about are preventive. However, the second function of vaccines is mitigation. Vaccines that provide mitigation, like the flu or COVID vaccine, may not prevent infection, but may mitigate the effects of the disease. Vaccines that are mitigative may also be preventive, but at lower levels than vaccines that we describe as providing immunity. I think if we explain this difference to the public and in clinical settings, we might educate people to understand better with respect to what vaccines do and don't do. Next slide, please. Key organizations in global vaccinations include the World Health Organization, Gavi, the Vaccine Alliance, and UNICEF. Together, they lead global vaccination efforts by coordinating funding, policy frameworks, and operational support. These organizations collectively reach over 20 million children annually in low and middle income countries, enabling mass immunization campaigns and vaccine procurement at subsidized prices. They also collaborate with national governments and other stakeholders, such as the Gates Foundation. Those collaborations are critical to achieving equitable vaccine access worldwide. Next slide, please. Vaccine against diseases like measles, polio, diphtheria, tetanus, pertussis, and more recently COVID-19 form the backbone of global immunization programs. The introduction of pneumococcal and rotavirus vaccines has drastically reduced childhood mortality from pneumonia and diarrheal disease, two leading causes of child deaths worldwide. Next slide, please. Widespread vaccination not only reduces targeted diseases, but also strengthens herd immunity, decreasing community transmission rates. Studies indicate that vaccination programs contribute to improved school attendance and cognitive development by preventing illness-related absenteeism. Economically, they reduce healthcare costs and increase productivity by lowering disease burden, enabling people to earn a living and care for their families. Next slide, please. Governments provide regulatory frameworks, budgeting, and public health infrastructure essential for vaccination programs, while NGOs often fill gaps in outreach and community engagement. In countries like India and Nigeria, government-led initiatives supported by NGOs have expanded immunization coverage by over 30% in rural and hard-to-reach areas. Public-private partnerships also enhance cold chain systems and training of healthcare workers, improving vaccine delivery quality and reliability. Next slide, please. The Immunization Agenda 2030, or IA 2030, sets an ambitious, overarching global vision and strategy for vaccines and immunization for the decade 2021 to 2030. Its greatest success, in collaboration with many governments and organizations, was the eradication of smallpox, officially declared eradicated on May 8, 1980. This occurred almost exactly 184 years after Dr. Jenner injected cowpox pus into his gardener's son. Next slide, please. Who measures what's known as zero-dose children? Those are children, that's defined as children who did not receive their first dose of DTP, a vaccine containing diphtheria, tetanus, and pertussis immunization compounds. According to UNICEF, the number of zero-dose children increased by 2 million since 1920 and 5 million since 2019. So there are some challenges, and I'll be speaking more about them. A success noticed on this slide is the continuing increase in the number of first doses of HPV vaccine from 27% in 2023 to 31% in 2024 among eligible girls. Next slide, please. So again, just a factoid here, global vaccination coverage for DPT, again, diphtheria, pertussis, and tetanus rose from 72% in 2000 to 86% in 2019. Expanded immunization programs have helped reduce under 5 mortality rates by an estimated 50%, reflecting the substantial role of vaccines in improving child survival. However, coverage gaps remain, particularly in conflict-affected and impoverished regions. Conflicts such as the war in Gaza slowed access to child immunization and recovered somewhat after the ceasefire took hold. Next slide, please. Before measles vaccines were introduced in 1960s, measles was a leading cause of child morbidity and mortality worldwide, responsible for more than 2 million deaths annually. Between 2000 and 2018, stronger health systems and increased measles vaccination coverage resulted in a 73% global decrease in mortality. As measles is so contagious, very high vaccine coverage, around 95%, with 2 timely doses of measles-containing vaccine, is required to prevent its spread. Coverage with the first dose of measles vaccine has plateaued globally at around 84% over the past decade. And although coverage with the second dose has increased to 69%, that percentage is not sufficiently high to prevent transmission. And we have seen an alarming resurgence in measles cases and deaths in recent years. Next slide, please. As I mentioned, smallpox eradication in 1980 remains the landmark achievement of global vaccination. Polio cases have declined by over 99%, with endemic transmission now limited to only 2 countries as of 2023. Additionally, measles deaths have declined by 73% since 2000, showcasing how sustained vaccination campaigns can eliminate or drastically reduce deadly diseases. Next slide, please. The Global Polio Eradication Initiative, known as GPEI, represents a public-private alliance, including the US CDC, UNICEF, the Gates Foundation, and Gavi. Polio paralyzed or killed over 500,000 people worldwide every year at its peak in the 1940s and 1950s. It has decreased across the globe since GPEI's inception in 1988. An estimated 20 million people are walking today who might otherwise have been paralyzed, and more than 1.5 million people are alive who would not have survived this disease. Next slide, please. However, polio elimination is threatened by cutbacks. The USAID cuts that we're aware of, the Agency for International Development has been decimated by this administration. It included cuts of $131 million to UNICEF's polio immunization program, which paid for planning, logistics, and delivery of vaccines to millions of children. In 2024, wild poliovirus type 1 remains only in 2 countries, Pakistan and Afghanistan. A quote from a WHO officials puts it this way: "We are at a tipping point. Either we invest now to finish the job or risk a global resurgence." Next slide, please. Gavi, the Global Alliance for Vaccines and Immunization, supports vaccines against 20 infectious diseases, including Ebola, malaria, Mpox, and rabies in low and middle income countries. Since 2000, Gavi has helped to immunize over 1.2 billion children, helping to halve children mortality in 78 lower income countries. Next slide, please. Inequities persist, however, between higher income countries and lower income countries. Vaccination for hepatitis B among infants is as high as 79% in the World Health Organization's Western Pacific region, while it's estimated at only 17% in the Africa region. For HIV, the Haemophilus influenza type B vaccine, which can cause meningitis and pneumonia, not the vaccine, of course, the virus itself. The WHO European region is estimated to have 93% coverage, while it is only 34% in the WHO's Western Pacific region. Maternal and neonatal tetanus persist as public health problems in 10 countries, most strongly in 10 countries: Afghanistan, Angola, the Central African Republic, Nigeria, Pakistan, Papua New Guinea, Somalia, Sudan, South Sudan, and Yemen. And the chart on there shows coverage, global COVID-19 vaccination coverage, and quite high in the developed regions and quite low in some of the low-income regions of the world. Next slide, please. Despite advances, these inequalities persist, with coverage in low-income countries lagging behind high-income countries. Geographic barriers, cold chain infrastructure gaps, and political instability compromise vaccine availability. Next slide, please. WHO listed vaccine hesitancy as one of the top 10 global health threats due to misinformation spread via social media and cultural mistrust. Studies show that up to 30% of populations in some regions express reluctance, fueled by safety concerns or conspiracy theories. Addressing this requires targeted communication strategies and trusted community advocacy. Next slide, please. The cost of vaccine, funding gaps, and lack of trained personnel constrain program scale-up, especially in fragile economies. The example being shown is that cold chain maintenance can account for up to 20% of vaccine delivery costs. Innovative financing mechanisms like Gavi's advanced market commitment help bridge funding, but sustainability is a concern as donors' priorities shift. Next slide, please. So, as I said, I'm going to end on a little bit of a hopeful note. The fight against vaccine-preventable diseases continues. The Coalition for Epidemic Preparedness, also known as CEPI, grew out of the 2016 Ebola outbreak. CEPI was founded in 2017 by Norway, India, the Gates Foundation, Wellcome, and the World Economic Forum. Now over 30 countries support it, as well as private companies, including Lululemon and Goldman Sachs. Its goal is to enable the Ebola vaccine to be stored in a regular refrigerator instead of, as it currently needs to be, a freezer at ultra-low temperatures. As we were mentioning, cold chain challenges can add greatly to the cost of trying to get vaccines to the people who need them most. Next slide, please. Emerging technologies such as mRNA vaccines, viral vector platforms, and nanotechnology promise faster, more adaptable vaccine designs. Research into universal vaccines against influenza and pan-coronavirus vaccines aim to offer broader coverage. Additionally, thermostable vaccines can overcome cold chain challenges, improving reach in remote areas. Next slide. Finally, future strategies focus on integrating vaccination into primary healthcare, enhancing community engagement, and leveraging digital tools for real-time data monitoring. Addressing social determinants of health and incorporating behavioral insights to counter hesitancy remain priority areas. Public-private partnerships will drive resource mobilization and innovation diffusion. Thank you so much for your time today. I appreciate the opportunity to present. Thank you.
Thanks, Stuart. I think what your presentation did was really highlight the complexity of vaccination efforts, obviously at the global level, particularly around access, supply chains, and some of the broader structural challenges that are out there. I think what's important to recognize in these global dynamics is that they move and that they shape how vaccines are understood and discussed here in the United States as well. And so that's my sort of rickety segue for Jillian. So as we shift from the global perspective to more of a national one, I'm going to turn it over to Jillian.
Thank you so much.
You
Hogan,
bet.
it's really nice to see you all here today. Thanks everyone for coming to talk about this really important topic. I'm really excited to have a chance to talk with you all. I direct the Harvard Opinion Research Program, and I spend most of my time conducting surveys and doing qualitative research with members of the public to find out about their views on vaccines, sort of why they do and don't make different vaccine decisions, why they do and don't support different vaccine-related policies. And my greatest love is then to share that information with practitioners who are going to be putting this into good work. And so I'm excited to have a chance to talk with you. I talk with a lot of public health agencies too. It's pretty fun. So I'm looking forward to the Q&A as well. And what I'm going to share is a couple of sort of pieces of research. I know everyone's like, Harvard research, that sounds boring. Swear it's going to be interesting. It's going to be really fun. And I'm going to share a little bit of my research about what people think. And I'm basically going to try to set the record straight, as it were. So I'm going to throw up my slides for a second. Put these guys up. Okay, so this is me. And so I titled this sort of what do people really think about vaccination? Because I think at the moment in the US, and I'm not here to paint like a super Pollyannish kind of, everything's going to be fine perspective. I think there are some real challenges. But I think the media in particular has sort of portrayed the public sentiment around vaccines as sort of like nobody likes vaccines anymore. Just like nobody wants to get them anymore. And I'm here to say that's not true. There are some important dimensions where we see some challenges for sure. I spend most of my time thinking about those. But I also think it's important to get the narrative correct because when we don't, it kind of gives power to people who might suggest, different kinds of information or misinformation that would maybe not support people in the decisions that are best for them. So not giving people a sort of a sense of things. The more you say like people don't like vaccines, the more people are like, well, maybe I shouldn't like vaccines, right? And that's not right. People need to be able to make the decision for themselves and really hear like actually these are well supported by a lot of people, not just experts, but by the people around you. So we're going to focus on three different issues. First is that the views of childhood vaccine policy are not what the media seems to say. The second is we're going to talk about vaccine misinformation. It's not viewed by people in the same way that health organizations view it. So we got to be careful with the language that we use and the way we talk about it. And third, this is a smaller piece of data, but I feel like everyone needs to see this, particularly practitioners. So I put it in every presentation I can possibly put it in, which is that people really don't think they need vaccines, even if they're in the target patient population. So right now, our new vaccine recommendations talk a lot about people at high risk and so forth, and people don't get it. So you as practitioners have a really important role to play in helping people understand their true risk profile and being able to make the decisions that are right for them when they have that information. Okay, so let's talk about it. As I mentioned, I mostly do surveys. These are big nationally representative surveys. I use online and phone panels. And I'm going to be showing a number of different surveys. There are about 1,200 to 3,400 people in each of the surveys. They're all in English and Spanish. We do a lot of statistical stuff to make sure that it looks like the true population, so you have confidence in the results. And the studies range all the way, I'm tracking issues all the way pre-COVID, 2019, if anyone can remember back that far. There was a big measles outbreak, so I was tracking vaccine stuff then, which is quite handy because we can see what's happened since then. Okay, so I promised the first issue that we're going to address is that the views of childhood vaccine policy are not what the media tell you. We have published some of these results, so you can look for that as well. I'm grateful for funding from the Beaumont Foundation and RWGF, as well as our work with CDC, ASTO, and NIFIC. Okay, so I'm going to tell you just straight off the bat, we ask people and have asked people for a long time, should parents be required to have children vaccinated against preventable diseases, or should they be able to send their children to school without being vaccinated against those diseases? This is the basic backbone of policy of childhood vaccination in the United States. There are medical exemptions for in every state, and religious exemptions and personal exemptions in some. But we frame the question so that people say, hey, you know, as you may know, children who can't get vaccinated for medical reasons aren't required. Like, we give them all the stuff, and then we say, like, what should they be? And surprisingly, even though you might not find in the news, most people do, about 4 and 5. And I will say off the record that I have seen more recent data, and it holds up. So this is not dramatically changing, even though the story about what's happening is. And it's been this way for a while, in fact. So it was a little higher in September 2019, but it's kind of been really stable. It's like a little higher, a little lower. These aren't huge statistical differences, and they're not huge, like, meaningful differences, even when they are statistically significantly different. So actually, public sentiment around vaccine policy is pretty stable. I think my sense is that it took a little bit of a hit in terms of COVID, because people were thinking that they would be requiring COVID vaccination. People got nervous. But we're not seeing a huge kind of resistance to school-based policies, even under changes in the current administration, which have weakened some of the ability to implement those. It's also interesting that there are partisan differences. So I look a lot at sort of how politics and people's views and culture kind of shape these views. It's not as though it's a hugely divided issue. Again, you wouldn't think so from watching the news. There is clearly more support among Democrats at 90% than among Republicans at 68%. So it's a difference. I'm not going to, it's not, but it's still more than 2/3 of Republicans say that this should be required. So broadly, there's a lot of agreement. There's a little bit more difference when you talk about vaccine safety, which is sort of a topic for another day. But in terms of sort of the policy support we have in the United States, it's really widespread, and it's really across lots of different people. And again, you wouldn't know it if you just read the news. Now, the reason that this is so important is sort of like when we try to understand, like, okay, what are people opposed to when they say, actually, you know, I don't want this. I don't think that parents should be required. They should be able to, you know, have their kids go to school without getting vaccinated. I think a lot of people think that it's going to be around safety issues, like they're worried that the vaccines are not safe. What's interesting is that it's true, 40% of those who oppose these kinds of requirements say that one of the major reasons is that they don't think the vaccines are safe for many children, but it's only 40%. As opposed to the top reason, really about parents' choice on whether or not to vaccinate their child. And similarly, or sort of close in number, people are worried that government agencies are influenced too much by politics and big corporations. They worry about a slippery slope where children might be required to get too many vaccines in the future. Again, COVID really brought that strongly out. They're worried about, you know, the existence of the vaccine sort of as a moneymaker. That seems like it's a common concern that we hear among people who have more conservative perspectives on policy, is they're worried about the sort of financial gains for those who are in power and implementing these policies. But I think it's important because I think as practitioners, you know, we're sort of always at the individual level, we may be thinking like this person really is concerned about what's happening for their child. And that's a really important perspective. But more and more, it's also about like, well, I have the right, I have the choice. It's sort of in my hands. I want to have agency over what my kids are doing. And I think that framing around health choices is coming into the play in a lot of spaces, not just in vaccines, where we're seeing that sort of both individual responsibility, so to speak, individual blame, and individual rights are really kind of helping to shape the narrative in a dominant way around a lot of different policies. And when it comes to children, that's a very kind of compelling argument for a lot of people. And so it's important to be thoughtful as practitioners about the way that we can come with empathy for that sentiment, and also be mindful of the way to keep children safe, and to give them an environment where they can have the right to be educated in a way that they are not going to be at risk for major illnesses that would cause them intense harm or even death. So it's something I think that we want to think about as we think about sort of the policy issues and conversations that we're having. As many of you know, we're coming up on the midterms later this year, and I'm certain that this will be one of the key topics that is talked about. So I think from a sort of practically what we do perspective, what do we think about? One, I think we can help create a more grounded vaccine environment by spreading the word that most people across parties support requirements, and seeing that there are some issues that are actually more bipartisan, more nonpartisan than we think. It's in a lot of elected officials' interests to say that we are more divided than we are, but we really actually are more united as a country and as people. And then thinking about ways that we can consider, and again, come with empathy, not with frustration, that vaccine policies that people who oppose it are not just talking about safety. And so our conversation, if you're working in a public health agency too, is thinking about not just safety concerns, but thinking about anticipating those more complex conversations around parental rights and keeping kids safe as a collective, and making shared community-based decisions. Okay, the next topic I'm going to talk about is misinformation. This is a word that's thrown around quite a bit. And I'm going to guess from one of the poll answers where people, 99% of folks in this room were like, vaccines are great. That when you hear the word misinformation, you're thinking, oh, misinformation means untrue, negative information about vaccines. And I want to say that when we use that word, actually, that's not always what the public is thinking of. So we have to be careful about the way we phrase things, the way we talk about it, when you're engaging in public-facing conversations, particularly. And again, this is actually, I should have updated the slide because this manuscript came out, but we published these results earlier this year in Health Security. So like many health practitioners, the public has deep concerns about false information. And a little more than 3/4 people say that the spreading of false information and false and inaccurate information about vaccines in the US is a major problem, with almost everyone else saying it's a minor problem. Very few people say it's not a problem. Now, what's interesting is that false information is not universally seen as malicious. So I find this is one of our most important findings. I love this finding. Now, what are these different bars? I'm going to say there are kind of 3 options, right? So one is that the information would be mostly spread by people who know the information is false, but they spread it for their own interests. And only about 1/4 of the public says, yeah, that's really like what the majority of misinformation is. It's like bad actors, okay? Now, on the other sort of end of the spectrum, about 1/4 of people say, well, most information is actually from people who think the information is true and they want to help others. They're like, benevolent people. And then about half people, and it kind of comes out to like just a bare majority, think that it's like kind of equally these 2 groups. But what I think is really important from the practitioner perspective and from the public health perspective is that this means that about 3/4, right, of people don't think it's malicious actors for the most part, right? They're not sitting like the health, a lot of the sort of conversation in health organizations is like, oh, those people spreading misinformation because they, like, I'm not sure what the next part of that is. But I think we have to take that out of the way that we think about it, because a lot of people are thinking about like their aunt and their uncle and their dad or their sister who sent them something like a reel on Instagram, and it was in the best of interest, right? They have their own interests at heart, and they're like worried about the vaccines. Like, I don't know if you want to get this for your kids. And so I think, again, pulling away from a common narrative in health organizations where there's sort of this malicious bad actor perspective, and more thinking about the fact that, there's a lot of good people who are worried about vaccines and who spread information because they don't know. And so we got to be careful that we talk about it so we don't alienate people who don't see it the same way that many health organizations might. I think it's also important to understand that, when we ask people, have you personally heard or read information about vaccines that you think is false and inaccurate? And about 2/3 said yes, they personally have. So they've experienced, so to speak, false information. But again, what that was is different than what we think. So only about like under 3/4 are thinking about misinformation in the way that health organizations think about it most commonly, right? It's negative information about vaccines. So they're saying like vaccines are harmful. And so that means that the people saying it like actually think, if they think that's misinformation, they think it's actually beneficial, right? So it's a little bit of a double negative there, but hopefully that makes sense. Like these people are like, yeah, the information I get is negative and it's wrong. And so we asked, well, what are the examples that you can think of the false information that you might have heard? And then we sort of organized their open-ended responses, looking at it qualitatively. And there are some things that are sort of like really objectively not true and negative, right? Okay, so vaccines allow the government to track the population. That was a very common sort of point of misinformation. I think the evidence for this is uh, zero. But and it sort of clearly kind of would fall into the sort of the kind of perspective of being like a rumor or like true total falsehood, right? Or vaccine changes the DNA, which there have been some health professionals who have suggested this, but it's been quite limited perspectives. And I think for the most part, this is like sort of objectively very obviously not true. But there's some things that are a little actually true. They are negative, but they are true, right? So vaccines give people the virus or contain live virus. Actually, I worked a lot with the Global Polio Eradication Initiative, and in fact, oral polio vaccine can give someone polio. It's vaccine-derived polio. And so this isn't necessarily what this person was talking about. They might have been talking about a case where it's not, but it's important to not say like, well, all the negative stuff about vaccines is untrue, right? Because that pushes people away. They're like, well, there's some of it. You have to acknowledge like there are some harder things about vaccines. Like there are some risks. Sometimes it doesn't work out. At a population level, it's amazing. It's a miracle. The individual level, it's a little bit different, and helping people to reconcile that is part of the job as a practitioner. The idea that they have severe side effects or cause adverse events or harms outweigh the good, like it's sort of a more extreme statement, but it's not totally untrue. There are negative side effects to some vaccines. So I think it's important that we give a more nuanced answer. And I think people during COVID became very frustrated with like, this vaccine is great. There are no effects. And then there may be some risks or, may not be needed for everyone. And that more nuanced explanation was difficult, and notwithstanding it's super challenging to have a nuanced conversation at a global pandemic. I get that. I was on the front lines of it, but I think it's a lesson learned in the way that we go forward with communications around vaccine. And then I think it's important to remember that there are 71% who said like, yeah, I hear misinformation and they're thinking about negative things about vaccines. But about a third of the population, when you say misinformation, they are thinking about things where vaccines are beneficial. Okay, so they're thinking about things that sort of imply like, actually, they might think that the vaccines are truly harmful and this misinformation is trying to trick them into liking vaccines. And we heard that as well. And so what's interesting here is that, it's sort of like about 30% were about issues around vaccine safety and 75% around sort of vaccine effectiveness. These are kind of the major categories of the kinds of things that people were saying. And what's interesting was I look at them, this issue actually that was just mentioned by Stuart is that this misunderstanding around vaccines, some of them, are, make it less likely for you to get sick and less likely to get very sick if you get infected. They don't necessarily prevent the disease entirely. And that was really sort of an important distinction that wasn't made clear to a lot of people during COVID. And in fairness, like we weren't sure exactly what was happening as the vaccines were being rolled out. But people only came to the understanding that vaccines can kind of make it better even if you're going to get sick. There was a much larger perception around that vaccines just prevent you from getting illness or getting sick in the first place. And now we have a more kind of, I think, a better messaging around what vaccines can do. But it was a rough learning curve there because people like, they don't work. I got the vaccine and I still got COVID, right? I think we probably all heard that message. And it's like, in your heart, you want to be like, but you didn't go to the hospital, right? Like you didn't die, right? And even though people don't like to hear that in response, and I don't recommend that right back in someone's face, the point is that as we think about how we educate people, how we talk about vaccines, talking about the fact that like, yeah, this could make it go from like a lion to a kitty cat, but it's not going to necessarily mean that you don't get sick at all. Like you can still get the flu with the flu vaccine, but you're going to be much better off. It's going to be much less, people, and you won't be as likely to get it. People don't think in probabilities very well. So it's challenging, but I think it's kind of the next evolution of the more effective vaccine communication and messaging that we can do together. So again, these are some of the things that I think are kind of interesting because it's not that all of these things are not true either, right? So it's sort of like, this is like, it's not like, oh, they heard misinformation and it's a positive thing. It's like, yeah, actually, to say that vaccines have no side effects is kind of misinformation. So just sort of acknowledging and being humble when we talk about the way we talk about vaccines. Okay, so what do I think this means? I think for practitioners and for those in public health agencies, and hopefully some of you will be in that space as well, recognizing the complexity of the concept of misinformation and how we consider the way we talk about that really importantly. Avoiding language and framing that might inadvertently shame or disrespect someone who spreads misinformation, because again, that might be someone's aunt or sister or themselves. And we want to embrace and come with empathy as we're helping people make decisions that are right for them. And then avoiding these sort of blanket positive statements like vaccines are always great. There's never any side effects like, oh, the reduced are almost not like, just acknowledging the risks in context without exaggerating them either on the positive or the negative side. Okay, that says to me I have 1 more minute, so I'm going to share my, and set expectations about effectiveness to the earlier point about making sure that we don't talk about vaccines as fully getting rid of making sure you never get a virus, but making sure that you're going to be less likely to get it and more likely to get a milder case if you do. Okay, this is going to be a really quick one, but I do want to tell you because this is really important in the context of the new recommendations, particularly around flu and COVID, which are now authorized for older people and people at high risk. And I want to just show these data because I think it's important. People don't understand what that means and they don't know it's them. So this is a data from a while ago, but I think the findings are still relevant. We asked people whether or not, if they got COVID, whether they would be at high risk of getting very sick. And about 24% of people said yes, they would be at high risk for getting very sick. And most people said no. If I got COVID, I'd be fine. Okay. So you're like, well, maybe that's kind of true. Like, think about like the prevalence of the things that make you at high risk, okay. But here's what's really important. We then asked people, okay, of those who are 65 and older, these are the people who are eligible for the vaccine and recommended to get the vaccine. Only about a third of them, or maybe 40%, fair assessment, said yes, they would be at high risk for getting sick. Only 40%. And we asked people if they had underlying medical conditions that make you at high risk for getting a serious case of COVID. Only a third said, yeah, I'd be at high risk. So when people have an image of who's at high risk for COVID, they've got in their head like a very frail, very old person. And nobody thinks of themselves that way. So again, you as a practitioner have this very important role to play in explaining, here's like the technical language. And it doesn't mean that you're like super frail, but you know what? The alveoli on your lungs are they're older, like, right? We have some wrinkles, we have some like lung, that's just like facts. And that's okay. The vaccine can help protect you against getting seriously ill. And so making sure that people see themselves and thinking together about how we communicate that more effectively and don't, again, sort of alienate people or make people feel like that's not me. Because they should look at the commercials and be like, that's me. I need that. And so important message for us as we connect with people. So again, people who are eligible for vaccines may not understand standardized messaging. And so finding motivations that connect with how they do feel about themselves and how they do identify is really important. And aligning with more age-inclusive and health-inclusive images and language that describes eligible groups, I think will really go a long way. Okay, so this is me. I look forward to talking with you all at the end, and thanks again for having me.
That was great. It was really insightful. It was interesting to see, how the interplay between like vaccine confidence and public perception and the misinformation that gets floated around and how that sort of affects everything at the national level. So I think the next question is how those dynamics transfer into practice, how recommendations are made, how the system responds, the overall systems respond, and how access is maintained at the state level, which again is my rickety segue into our third speaker, who is going to speak at the more state level. It's going to be Angela Fowler. Angela?
Thank you. Good evening, everyone. Very happy to be here with you today. Thank you for the invitation to this very interesting conversation. So I'm very happy to be with you today to talk a little bit about how we at the Department of Public Health are protecting public health in an age of challenging federal vaccine policy. So I will venture to say that everyone who works in public health will probably agree that beginning about a year ago, federal vaccine and more broadly, public health policy has been very challenging. So this has been very challenging, very chaotic. Um, Penny, I'm seeing, I think since you're sharing my slides, I think I'm seeing you in kind of the speaker format, but where we
Yeah,
were
I'm trying.
before.
Here's your first slide,
Yeah,
and I can't seem to just get you. Um, I will turn my video off, but it doesn't help. I go to layout, I go show meeting. I don't want that. Remote control. I can go here
well,
side by
I'm okay
side.
with my slides look a little small, as projected. Uh,
My screen, they're totally, the slide takes the whole page.
I think it's because you're in presenter mode. Do you want I think the way
There
I'm
you,
seeing it, sorry.
all right. This says I'm screen sharing and I can't get it.
You
Asmay, can you see this?
Yes, I was just gonna send you a picture. Try to right click on the PowerPoint and see what options it gives you.
Okay, nope, that's not doing anything. What's this one do? Nope, that gives me the whole thing. I don't want that.
I can try to share mine. I can try to share it if you want me to try.
I don't know what has happened. I can't believe this.
And so do you want to try to see what it looks like on your end?
I'm going to
I can try
stop
to pull them up
share.
as
I'll
well if you
stop
want.
Okay.
share here.
Yes, it's the Zoom gremlins. Let me let me try. Um,
All right, this says you've started sharing.
mhm. And
Move your all the start slideshow from the beginning and let's see.
how's
You-
that?
You're doing a great job now.
Okay, is everything
Everything
okay?
looks wonderful. Your
All
side grew to me and it looks wonderful. Oh,
right.
we got a hand going up saying great. Thank goodness.
All right. Excellent.
Oh
Excellent.
my
Okay.
Lord.
No worries. Thank you. No, so I was just going to say, I'm happy to talk a little bit about how we at the Department of Public Health are handling kind of a challenging time for us as far as vaccine policy is concerned. And I was just saying, we've been experiencing some challenges, and the perception that the federal vaccine policy has been very chaotic over the past year. And I put in this picture of a roller coaster because it's kind of felt that way, mostly kind of going down. We've had a few ups, but kind of it's been quite a challenge as far as federal vaccine policy is concerned this past year. But what I will say is one of the good things, one of the ups, is that Massachusetts continues to be very committed to evidence-based vaccine policy, and we have commitment from the governor to the commissioner of health, all the way through Department of Public Health and local public health departments. So that I think is has been really great to see. So I'll talk a little bit about how vaccines are typically recommended in the United States, because I think most times historically it's really been in the background. Most people don't really think about vaccine recommendations that much. I've heard it quoted that effective public health is invisible, and I think that's true. We don't really think about it typically. So what typically happens with these very important public health tools is that there's a very systematic and scientific process that gets them from the research that's done to support their safety and effectiveness all the way through to recommendations and implementation in the clinic. So as you probably know, before vaccines come before any federal agency, there's typically a lot of basic science research, clinical trials demonstrating safety and effectiveness. The vaccine manufacturer then packages all of that data that they've collected, and they send that in an application to the Food and Drug Administration. The Food and Drug Administration reviews all of the data related to this vaccine product, and if they review this product and they find that it is safe and it's effective, they will license it to be used in the United States. And when the FDA makes licensing decisions about vaccines, they generally will say this is you can use this product in the United States and give kind of general guidelines. But the specific guidelines are provided by another group that's called the Advisory Committee on Immunization Practices, or ACIP. And the ACIP is a group of, it's a committee of experts from around the country. It is not a government, it's not affiliated, or it's not part of the government. It's supposed to be independent of the CDC and the government agencies. But it's people who are expert in vaccines who consider how this vaccine, this new vaccine product, should be used, and who should get it, and how many doses should they get. And so every new vaccine that's licensed by the FDA has to be considered by the ACIP by law. They have to consider it and make recommendations on it. So that's typically what happens. The ACIP meets. It's a group of, again, scientists and physicians that have demonstrated expertise in the area of vaccines. They are heavily vetted for conflicts of interest, and they meet in public. And you can go to YouTube and pull up their meetings, and when they have it live, you can watch the meetings live. So they meet and make these decisions about how vaccines should be used. But before the ACIP actually meets, there are work groups, and the work groups do a lot of the heavy lifting when it comes to making vaccine recommendations. The work groups, which are composed of members of the ACIP, but also subject matter experts from the CDC, professional organizations, professional medical organizations play a large role traditionally in helping develop these recommendations in the work groups, scientific experts. So there's a large number of people that invest a large amount of time developing these recommendations so that they can be prepared to go before the ACIP. The ACIP, once the work group is done, the ACIP will review the work of the work group and kind of discuss further, or send it back to the work group sometimes, or vote on it. And then once the ACIP votes on recommendations as far as how to use a new vaccine, that's a very important decision. It eventually will go to the CDC director for approval. And once it goes to the CDC, once the ACIP recommendations go to the CDC director approves it, and then it becomes the recommendations of the CDC. These recommendations are very important because, one, they give guidance to clinicians on how to use these vaccines. So that's a very important aspect of what the ACIP does and why the ACIP recommendations are so important. But on the other side of it, ACIP recommendations also link to coverage of vaccines. So by law, insurance companies have to cover vaccines as recommended by the ACIP. So that includes all of the kind of private insurance, public insurance. They all have to kind of follow the ACIP guidance. So, but the problem has been is over the past year, we've noted disruptions to this kind of traditional systematic scientific vaccine recommendation process. So it's been at kind of all levels. So at the FDA, we've seen some the FDA associated with this administration seems to have concerns about RNA mRNA vaccines and COVID-19 vaccines. And so what they did was restricted the licensing of COVID-19 vaccines just to certain populations. In terms of the work groups that I was telling you about that do so much work to develop the actual recommendations to present to the ACIP, the organizations that typically contribute a lot of work to the ACIP work groups were blocked from participation. So, for example, the American Academy of Pediatrics traditionally has been very involved in developing the recommendations for pediatric populations, and they were not able to participate in the work groups. And then also too with the ACIP, last year was reconstituted, and the new ACIP members really did, most of them did not have any vaccine experience, and also had documentation of vaccine skeptical views. So it was very concerning for most of us. So just to go through an abridged, abbreviated timeline, in June of last year, HHS dismissed all of the members of ACIP. And as I told you, ACIP traditionally has been very heavily vetted expert group, but this committee, everybody on the committee in June was dismissed. They said it was because these ACIP members had conflicts of interest. And then the ACIP was reconstituted with members that really didn't have any specific demonstrated knowledge about vaccines and or had expressed vaccine skepticism. So that was very concerning. In August, the FDA approved the updated COVID-19 vaccines. They licensed them, but only licensed them for adults over age 65 and younger people with one high-risk condition. And as Gillian was saying earlier, sometimes people don't really know what their risk level is. So that kind of restricting the licensing at the FDA level of the FDA, which is not typically their role. They would typically not do that. The ACIP would say who would get the vaccines. So that was another concern. In September, the ACIP, the reconstituted ACIP met, and they recommended individual-based decision-making for COVID-19 vaccines for children and adults. And previously, everyone was recommended to get COVID-19 vaccines. As you know, people have different risks for severe COVID. And so not specifically recommending for many people, including pregnant people who may have elevated risk associated with COVID-19, was not aligned with the science that we know about. Last December, the ACIP also, again, kind of in a non-scientific decision, removed the routine recommendation for birth dose hepatitis B vaccination. So the hepatitis B vaccination at birth, beginning that vaccine series immediately, has been one of the success stories in vaccination history and reducing the perinatal transmission and childhood transmission of hepatitis B, which is a very serious health-threatening, cancer-causing virus. And then finally, in January of this year, this did not go through the ACIP, which is a process issue. The HHS just issued a memo through the CDC and revised the federal childhood immunization schedule by removing several vaccines from the routinely recommended list and put them on the shared clinical decision or individual based decision-making recommendation. So that was concerning for many or most of us. And it's not so much that there were changes because, medical science changes. And that's, I think, one of the really interesting things about medical science. I went to medical school years ago. And, what you were taught then is not necessarily what you would be practicing now. So there is an evolution. The change wasn't the problem. The fact that things change really isn't a concern for most of us. The issue is that there was not really there wasn't the proper process to enact these changes. The people, in the case of the ACIP, were not necessarily knowledgeable enough to make the changes. The HHS issued a memo, and that's not the process of making recommendations. There's no new science to support changing recommendations. So there was pushback from clinicians, public health organizations, and major professional medical groups. And it just reminded me of a quote from Kevin Hall, who was a very prominent NIH scientist before last year. He said, science only complicates rhetoric. And it kind of felt that way, that you're kind of blocking the science to kind of promote, an ideology, which was what a lot of us were concerned about. So I'll point to one of the kind of, if we're looking at the roller coaster, this was one of the kind of up things, which was we did get some support in a legal action. So this legal action was pursued by the American Academy of Pediatrics and others who sued RFK and HHS last year after the ACIP was disbanded. And they added a number of other issues as well about the kind of challenging the legality of that action. And so the good news is that recently a federal judge, and they sued in federal court, a federal judge in Boston stayed many of those federal actions that I just described in the slides before. So the January 2026 memo, which had reduced the childhood vaccinations, was stayed because there was no science behind that. The judge also recognized that the reconstituted ACIP membership were not qualified based on the ACIP charter, which specifically says that ACIP members should have expertise in vaccines. So the judge said that wasn't the case. So the ACIP, as constituted by RFK, was not valid, and so they stayed that particular group. And then he also stayed all of the votes taken by the reconstituted the ACIP throughout the year, which there were a number of different votes that came up. So that was kind of, I guess, a good news. It's a kind of not necessarily a permanent situation. Things are just stayed, and it's not permanent. And one of the things that it's been reported and it actually was published in the Federal Register is that HHS is changing the charter of the ACIP so that it can include members that have other expertise. And so I think that it's going to be challenged, and the judge's temporary ruling is going to be challenged by the federal government. But I want to end by talking about how Massachusetts has responded to these challenges. So, like I said, it's been a challenge because there's been no new science kind of supporting the changes of these recommendations that were made over the past year. The judge kind of used the term arbitrary and capricious in terms of what was done over the past year. And so clinicians in public health, we've been trying to push back, and we have realized that we have to take the wheel with some of this because in our view, the federal government at this point is no longer a reliable source for evidence-based guidance around immunizations. So what DPH has taken a number of steps. One was around COVID-19 vaccines. So last fall, there was a concern that after the FDA limited the licensing for COVID-19 vaccines, we were concerned that the ACIP would not recommend COVID-19 vaccines at all. They ended up doing that, but we kind of preemptively took some actions. So Governor Healy and Commissioner Goldstein changed things. They worked with the Division of Insurance, which insurance companies have been just amazing partners in this. And so I mentioned earlier that insurance companies are required by law to cover vaccines that are recommended by the ACIP, but they're not obligated necessarily to cover vaccines that are not recommended by ACIP. But the insurers worked with Department of Public Health and came together and issued a bulletin that requires insurance carriers to cover recommendations, vaccine recommendations as per DPH, if they're not recommended by ACIP. There were also standing orders issued by Commissioner Goldstein to allow pharmacists to administer COVID-19 vaccines, because again, the importance of the ACIP recommendations, it provides authorization, or previously provided authorizations for pharmacists to administer vaccines. So if it wasn't recommended by the ACIP, then the pharmacist wouldn't have that authorization, but Commissioner Goldstein stepped in and provided the standing orders to allow for that. And then the third change was that the Commissioner Goldstein updated the vaccine administration policy to permit the commissioner to decide which routine vaccines could be administered by pharmacists, rather than just limiting to the ACIP recommendations. So the ACIP had also, over the course of the past year, issued a number of recommendations that were not aligned with science. So in that case, we issued guidance for clinicians to kind of recommend what we think are the best evidence-supported guidelines for clinicians to use to vaccinate their patients. And when the memo at the beginning of the year was released, kind of reducing the recommended number of vaccines for pediatric immunization, we also, again, released guidance to recommend that physicians that are immunizing children follow the American Academy of Pediatrics recommended immunization schedule. The AAP immunization schedule for many decades was very much like the CDC schedule, with only just minor differences, but now the AAP is the reliable source for vaccine recommendations for clinicians. So that is what we're recommending clinicians use, rather than the federal pediatric vaccine schedule. We get questions about the school vaccine requirements. The school vaccine requirements are always state regulated under state law, and those have not changed at all. So we have here our school vaccine requirements for entry into school or camp. Those have not changed. It's not the same as what would be recommended for kind of routine vaccinations. There are other vaccines that are included, but these are the kind of the bare minimum that a child would need to enter to register for school. And the other thing that we've done at the Department of Public Health is we have collaborated with other states. And so Massachusetts was one of the founding kind of states for the Northeast Public Health Collaborative. And it was kind of, the idea was for states to kind of get together and kind of align with each other on addressing some of these recommendations and endorsing evidence-based recommendations, because we thought it would be better to kind of come out as a group, and rather than Massachusetts recommending one thing and, New Jersey recommending another thing and New York recommending, we kind of all get together and kind of align and discuss things. So that has been really a really great thing to do, to connect with other states and work with them. So we're pointing clinicians to evidence-based guidelines, and we're also refuting claims about unfounded claims about pediatric vaccines and autism. Other activities that we do to support vaccination is we have developed contingency plans. The pediatric vaccines in Massachusetts are provided by the state, and those state vaccines are partially funded by through the CDC. If that funding goes away, we've developed contingency plans to maintain access to those vaccines in Massachusetts. We monitor pediatric vaccination rates through our annual school survey, and I'm happy to say that our routine pediatric vaccination rates are quite high, and they've remained quite high. For example, measles, mumps, rubella vaccination at the kindergarten level is 97% of kindergartners are fully vaccinated. So that's really good to see. It's been stable for a number of years. Respiratory illness vaccinations, we could do a little bit better. We also monitor those, and both the school vaccination surveys and the respiratory immunization dashboard are publicly available. And we collaborate with partner organizations to provide clinician education outreach, community education and outreach, and support mobile school and community vaccination events. So thank you very much for your attention today. If I had to say one thing, I would say that the science about vaccinations have not changed. The rhetoric in some areas, some corners have, and in Massachusetts, we're committed to maintaining vaccine access for our communities.
Thank you so much, Angela. That was fantastic. There was so much in there. It's so well delivered. Thank you so much. So I think what we're going to do now is I think we're going to move to, well, we can either move to questions in the chat or we can move to one of the questions that we've given to our panelists and have a Q&A that way. Penny, what are your thoughts?
I think we should open up one question to the panel and then do the Q&A with the audience. That's what I think.
Okay. So right now, I go ahead and open up, and I get to pick which question. Interesting.
Yeah.
So let's see here. I think I'm going to pick, so to the panel, if you could change one thing tomorrow, whether it be at the global level, in the public perception, or in policy implementation, what do you think would improve vaccination outcomes the most and why?
Well, first of all, I just want to say I'm honored to be on a panel with Jillian and Angela. What terrific presentations. Thank you so much. And I'm actually going to build a little on Jillian's, which is, wouldn't it be nice if there was a kind of health curriculum module for high school students that taught some of the things that Jillian is emphasizing in terms of let's be realistic about the benefits, but also acknowledge that there are some unanswered questions and no vaccine is perfect and there are some side effects, but let's maybe find a way to embed this in a way when people are still maybe a little more open and able to. So maybe it's pie in the sky, but that was the thought that came.
Well, piggyback on that, Stuart. I think that was actually kind of what I was going to say. I think over the long term, improving health literacy and numeracy and kind of the science, understanding the science so it doesn't feel like such a scary black box, I think it would be really really important. So I was actually going to say that, and I'll add too. I think scientists and physicians, I think we have to learn to be better health information communicators. I think, a lot of great clinicians aren't necessarily great at communicating, especially in the kind of the places where a lot of people are getting their information now, such as social media and things like that. So I think that improving the education of the population around science and health and Gillian mentioned, it is hard to communicate risk. And so understanding risk communication, I think that, and then also getting our scientists out there to communicate some of those things as well.
So yeah, I mean, I think, we said on the one hand, sort of educating the public, and the other thing, sort of educating, providing training for the public health teams and the clinicians. And so I'll emphasize the second half of that. So I'm here to say that public health can be fun. We are not thought about as fun very often. We are usually a party killer. We're like, please bubble wrap yourselves, don't touch each other, don't have fun, go home. But I think that we can be more engaging. And I think all of the folks in this audience who are clinicians, you have a really special relationship. When I do surveys about who people trust, nurses come up as one of the top. And I want to elevate that relationship that you are going to have and the trust people will have in you by the position you have. So I want to encourage you to use that as a place to bring a human perspective to this. Everyone is getting weird information on social media. They don't know who to trust. They're not sure about these influencers. The stuff was sent. They like people, but they're not totally sure. Like, it's very confusing. And while you won't see them very often, when you do, those moments in the office are important. And you have a really important power to be human with them, to not exaggerate risk and not exaggerate benefit, but to say, I hear you. I totally understand. Like, if you have a concern, this is what I think. And, I want to thank you in advance for the work that you're doing, because there's huge pressures, like to get patients through, and insurance pressures, and, and taking that moment to be seen as a whole person and be like, I know you're like struggling with this decision, and I totally get where you're coming from. That moment is really important. And you will have information about how vaccines work, where they're beneficial, where the risks are, and you can help people make a decision that makes sense for them and their families. And we know, like, way more often than not, it's going to be a decision that is to get vaccinated. And so helping people through that process is a really special role that you have. And so I thank you in advance for that work and for that human perspective that you can bring in the moment.
What a great set of answers that was. You guys worked really, really well off of each other. That was fantastic. Do we want to do the questions that are in the chat, Penny? And you're muted.
We have a few more minutes. Maybe we want to do the second question, and then I think we've got two. Well, maybe we should do the two questions that are in here.
And then we just got a new one in too.
Yeah, I think we should maybe go to those.
Okay, so what I've got here is I believe it's Bruce Gilman, and this is a question actually I had too. Questions for Stuart. Why wasn't HIV vaccinations mentioned in your talk?
Great question. I've enjoyed talking about HIV, and I think it's important that we do. So people have been trying to work on a true HIV vaccine since almost the beginning of the epidemic, certainly over 40 years. And there has not been what's considered a successful HIV vaccine to this point in time. And by that, I mean a vaccine that works with the immune system to prevent infection from happening. What we do have is something called injectable PrEP, which is not a vaccine, but it is an effective treatment for HIV that also works as a preventive measure. And it's mostly distributed up to recently in pill form that people were required to take daily. And it's now been refashioned into an injectable. There are two on the market. One is required every 2 days. 2 months. The other is required once every 6 months. There have been extensive trials trying to make this injectable PrEP accessible in low-income and middle-income countries. And unfortunately, the cuts to USAID and to HIV prevention programs that have happened in the US since the new administration have been devastating and actually have created great dilemmas for the researchers, because people who have been on these injections need to be followed because they're still in clinical trials. And many of them, uh, just there's been no staff to do that. It's a breach of ethics. The staff has really wrestled with this. I know people are working without pay to try and make sure there's follow-up for people to make sure there aren't unexpected side effects. And so uh, it's a long, complicated history and situation. But the short version is there's no vaccine that's been shown to have maybe greater than 30% effectiveness, which is why nothing has been approved. But there is this other form of treatment that is now administered by injection.
Excellent. Excellent. Thank you so much. And then this is Bruce again, but this one's for Jillian. And it says, what do you advise medical professionals do to counteract RFK Jr.'s misinformation about vaccines and autism and his other opinions not backed by scientific data?
It's a really important question. And I want to say that I strongly believe that um, if a person, so there's two sort of scenarios. One is sort of like just broadly, in your life and in your clinical work is, sharing information that you think is true, and following, some Angela outlined, here are some great resources that can keep you up to date. The science really hasn't changed, so it's pretty clear how safe and effective these vaccines are. And there is no credible evidence of a link between autism and vaccines. So I think being the person that says that is great. I think if you're also sort of in a situation where you're talking with someone and it feels like to them it's not misinformation and they're scared about it and they're worried about it, I think it's important to one sort of acknowledge that sentiment and be like, I totally get where you are, right? This is something you're going to put in your kid's body. I totally understand why that's scary. Um, and secondly, again, most people don't think that other people are spreading this information for ill ends, and that extends to RFK. So I think there's a lot of people who are like, he's a kook. And you're like, okay, keep those thoughts to yourself and just say, like, hey, I think there's, whatever your thoughts are about him, I think there's a really good argument, and many people believe that he believes it. Whether or not you believe it, he is not trying to harm children. He is trying to help them. He just has a really different perspective on the evidence. And I think we haven't really had that in public health before. And that is really scary for a lot of public health practitioners because we're like, wait, we thought we were kind of all on the same team. And so I think it's important to express a respectful perspective on even things that you think are like, no, there's no way, no one would believe this. Like, it's presented, you're not seeing the information they're seeing. And so coming to that from that perspective, you're going to have a much better conversation with people. And it's okay if in that moment they're like, this is not for me today. Keeping that door open is actually the most important thing you can do. If they feel alienated in that conversation, they're not going to come back to you for more information. So you have a window in the time where they're with you to just make that connection and to have them trust the health system that they see. We know there's a big link between people's experience in a healthcare setting and what they think about public health information. Even though public health doesn't want to think about it as part of healthcare, and healthcare doesn't want, there's like a weird rift there forever. Let it go. Because guess who doesn't understand that is everyone else. Nobody sees a difference between public health and healthcare. So get over it and just understand that we're all on the same team, and that sort of being with that person in the moment, extending that conversation and just be willing to hear them and talk to them about it is the best thing you can do.
Nice and thorough. That was fantastic. Thank you. So on my timeline, Penny, I've got that I am done and that we have 1 minute left. So I'm going to hand it off to you.
Oh, gee, thanks a lot. I can't tell you how long I spent practicing the slides and moving them and, all that. And I do apologize to the audience, but it's not that I was negligent. I do want to conclude the panel with a couple of things. One is that I want to thank our expert speakers without a doubt. You really helped us to understand why vaccines and immunization is at a crossroads. I mean, it is in a very difficult place. And your presentations were wonderful. Stuart, I wrote this down, you began with a global picture where vaccines continue to save millions of lives, yet progress is uneven and fragile due to the inequities, supply challenges, and the geopolitical forces. Um, Jillian, you then gave us a picture of the national landscape where public confidence, misinformation, and changing policy debates contribute to people's understanding of vaccine safety and effectiveness. And seeing your different studies and the outcomes and learning that people really see things differently. We think misinformation is one thing and they really see it as something else. And that is very enlightening to me. And Angela, you told us how Massachusetts is working to build strong immunization systems through tracking, accessing programs, partnerships, and public health infrastructure. And I had no clue that Massachusetts was working so hard and had so much in place to counteract what's coming down. And I also, as you were talking about the, I believe ACIP, one of my questions was, is this the same as the panel that RFK dismantled? And you answered that question. So that's a little frightening. To the audience as a whole, I want to thank you for attending. And I hope that what we've done here tonight really has helped you to see how you can interact. You really have a sense of the landscape now. And I hope this has made it a little bit easier in your practice in the future, and that you can really apply these things. And last but not least, I want to thank all our panelists, but I really want to thank Asma El Almani. This is her last panel with me, and it is very sad to have her graduating, although it's a good thing. And she's just been incredible and has gotten me out of many situations. And I really thank her a lot.